Hello and welcome. My name is Brianne Droste, and today I will be discussing teratogenesis associated with gastrulation. So the topics that I will be presenting today are going to be normal process of gastrulation, teratogenesis, haloprosencephaly, caudal dysgenesis, also known as cyrinomelia, and situs inversus. So today, first, I will begin by explaining what gastrulation is and the process of it. Gastrulation is the most significant event during week 3 of development, and it is defined as the process of transforming from a bilaminar disc to a trilaminar disc. This trilaminar disc then establishes all 3 of the germ layers, which are the ectoderm, mesoderm, and endoderm. All right, so at this stage of development, we have the amniotic cavity, we have the epiblast, the hypoblast, the definitive yolk sac, and the epiblast and the hypoblast is what making up the bilaminar disc. So gastrulation begins with the formation of the primitive streak on the surface of the epiblast, which begins to be clearly visible at approximately 15 to 16 days of development. And this is the primitive streak here. And this gives a means of orientation because the cephalic end of the disc has the primitive node that is surrounding the primitive pit. So here is the primitive node here. So then this would be the cephalic end with the oropharyngeal membrane. And over here is the caudal end. The primitive streak then begins synthesizing fibroblast growth factor 8, also known as FGF8. And the purpose of this is that it downregulates the amount of E cadherins that bind the epiblast together, keeping them in place. This allows the cells to detach from one another and they begin migrating towards the primitive streak. When the cells arrive to the primitive streak, they detach completely from the epiblast and slip beneath it, spreading laterally and cranially. The cells that migrate to the hypoblast become the endoderm, cells that remain at the epiblast become the ectoderm, and cells that migrate to form a completely new middle layer called the mesoderm, and that is controlled by the Bach-Uri T expression. Picture describes what I was explaining in the previous slide pretty well. So you can see that we have the primitive node, the primitive streak, the cranial end with the oropharyngeal membrane, the caudal end with the cloacal membrane, and you can see here that the cells of the epiblast start moving into the primitive streak and then spread laterally and cranially, becoming mesoderm. So this will then become the ectoderm. The red ones will become the mesoderm. And then some of those cells will also, you can kind of see that here, be incorporated into the hypoblast, becoming the endoderm. So the formation of the precordial plate begins when cells from the primitive streak begin to move laterally and cranially to the oropharyngeal membrane. And there is little to no ground substance. So here we can see the oropharyngeal membrane. And this, the purple with the stars, is the ground substance. And you can see that there is little to no ground substance in that area. This right here is the precordial plate. So we're kind of looking at a side view of the bilateral disc. So at the oropharyngeal membrane, there is little to no ground substance, and some of the cells from the primitive streak move towards the precordial plate and will intercalate into the precordial plate, displacing the previous hypoblast. These cells proliferate, forming another layer called the precordial mesoderm at the caudal end. So this is the cranial end, caudal end, and right here, that is the precordial mesoderm. And this will contribute to the formation of the head of the fetus. The oropharyngeal end over here, this area, is now restricted to the cranial end and eventually forms the mouth opening. The neural plate is important for the induction of the forebrain later on in the neural endoderm. Formation of the notochord. So we have prenotochordal cells that are moving cranially, so this way, and then they reach the precordial plate, which is right here. And they become temporarily intercalated in the hypoblast. As the hypoblast is replaced by endoderm cells, cells of the notochordal plate proliferate and detach from the endoderm, and this is forming the definitive notochord. So that is here. This entire length is the notochord. And this is important because it is the signaling center for inducing axial skeleton. Notochord and prenotochordal cells will then extend cranially to the precordial plate and caudally to the primitive pit. So this is the caudal, again, primitive pit over here, and cranial. Neuroenteric canal forms from the primitive pit, forming the connection between the amniotic and yolk sac cavities. Alloenteric diverticulum appears around the 16th day of development, and it is rudimentary in humans and may be involved with abnormalities of bladder development. So here's just another view of the notochord development. So we have the primitive pit here. We have the precordial mesoderm and the oropharyngeal membrane. You can see the notochord extending here. So the notochord plate almost kind of folds in. As you can see here, you can see it beginning to fold in until it becomes its own entity. Another event that is happening during this time period is the establishment of the body axis. So for the anterior-posterior body axis, these are cells destined to form the anterior visceral endoderm, and they are located at the cranial end of the endoderm layer of the bilaminar disc. These express genes essential for head formation, such as transcription factors OTX2, LIM1, and HESX1. Secreted factors that are important for this are Cerberus and Leafy1, which inhibit nodal, which establishes the cranial end. For the dorsal ventral, we have an absence of Cerberus and Leafy1 at the caudal region, which allows nodal expression to continue. And it upregulates numerous genes. For the left to right axis, this is regulated by nodal expression that is restricted to the left side of the embryo. Accumulation of serotonin activates MAD3, which helps keep the nodal expression to the left. And sonic hedgehog and leafy 1 prevent nodal from crossing the midline. And this will be important in our pathologies associated with situs inversus. So before we got into the pathologies, I wanted to talk about a little bit about what is teratogenesis. So teratogenesis is the creation of a deformed organism, and this is typically done through tetragens, which is any agent that physically or chemically alters the developmental process and produces congenital deformities. So examples of this can be chemicals, medications, drugs, alcohol, infections, and many other things. So what does teratogenesis really have to do with gastrulation? Well, during this process, in the third week of development, it is very sensitive to teratogenic insults. And that's because there are fate maps that are being determined for various organs. And the destinations of the epiblast cells that invaginated and migrated determine this. So the cranial node has the precordial plate and the notochord. The lateral node and cranial streak becomes the periaxial mesoderm, and the caudal streak becomes the lateral plate mesoderm, and the caudal-most streak becomes the extraembryonic mesoderm. And anything that interferes with this migration and development can cause deformities later on. Now we are going to shift over to talking about the pathologies. So the first pathology I'm going to talk about is holoprosencephaly. This occurs in every 1 to 8,000 to 1 to 6,000 live births, resulting from an incomplete midline cleavage of the forebrain. And this can cause a wide spectrum of intracranial and craniofacial midline defects, and can present either sporadically or syndromic association, and occurs around weeks 2 to 3 after conception and is a disorder of gastrulation. So clinical presentation, we have cyclopia, absence of olfactory cranial nerves, and related structures. Causes of this can be chromosomal anomalies, but they do have a normal karyotype. So genetic causes can be disruptions of the sonic hedgehog gene, SYNC2, 6-3. Non-genetic causes include pregestational maternal diabetes and a list of teratogens such as ethanol, retinoic acid, which is vitamin A, foodborne mycotoxins, and drugs that interfere with cholesterol biosynthesis. Gastrulation is reached 2 weeks after fertilization, and that is 4 weeks from the last period. So women may not know that they are pregnant, which means that they are not aware to take the necessary precautions in the case of like alcohol consumption. So pathogenesis, how does this actually occur? So development of the brain and the face occurs due to signaling between the surface ectoderm and the neural crest cells that determine the migration of the primitive embryonal cells. Incomplete diverticulation and cleavage of the embryonic forebrain results in intracranial pathologies. Blocking of this signal will alter the dorsal ventral polarity, anterior posterior axis, and inhibit the bilateral symmetry of the forebrain. So this inhibiting will impede the dorsal ventral polarity. And the various degrees of the block in the sonic hedgehog signaling will determine the severity of the disease manifestation. The next pathology that we are going to discuss is caudal dysgenesis, also known as sirenomelia. And this name was derived from the sirens of Greek and Roman mythology. It is a rare congenital anomaly seen in every 100,000 pregnancies. And it is characterized by the fusion of the legs into a single limb. Most are stillborn or die shortly after birth. The clinical presentation includes hypoplasia and fusion of the lower limbs, vertebral abnormalities, renal agenesis, imperforate anus, and abnormalities of the genital organs. So spontaneous mutations likely caused by genetic environmental factors is what results in this condition. Um, Things that can cause this is retinoic acid, maternal diabetes, heavy metals, abnormalities of the brochure gene, the WNT gene, and the engrailed genes. The pathogenesis is not completely known, but it has been associated with damage to the mesoderm. So insufficient mesoderm forms in the cotyledonous region of the embryo, and this contributes to the formation of the lower limbs, urogenital system, and the lumbosacral vertebrae. So because there is a lower amount of the mesoderm, the lower limbs do not form properly. Pathologies that we're going to talk about is situs inversus, and this is kind of an umbrella phase because there's a lot of different subtypes to this, but it's a rare genetic condition which organs are positioned in a mirror image of normal anatomy, and it occurs in 1 in every 10,000 people and is more commonly seen in males. So situs solitis refers to the normal anatomy position. Situs inversus refers to a complete reversal, and situs ambiguus refers to one or more organs abnormally reversed. So we're going to talk a little bit more about the subcategories of situs inversus, starting with situs inversus totalis. So this is a rare congenital abnormality characterized by mirror image transposition of both the abdominal and the thoracic organs. And normally this is asymptomatic. However, it can be associated with other pathologies such as Cartiger syndrome. And for the etiology, there's a family history of heart defects that's associated with this, maternal diabetes, antitussive use, which is anti-coughing medication, paternal smoking, and there may be a connection with gene mutations such as nodal, CCDC11, and PKD1K, and then PTIX2, which is the home box containing the transcription factor that is a master gene for establishing left-sidedness. So these all have to do with mutations in laterality. And pathogenesis is failure to establish the left-right asymmetry. The next subset of situs inversus that we are going to talk about is situs ambiguus. So this is associated with the abnormal position of the midline organs and vessels, occurring in 1 in every 10,000 people. And it clinically presents most commonly with cardiac heart disease, which is seen in 50 to 100% of cases, and also has a very wide variety of signs and symptoms depending on what organs are involved and how greatly they are involved. So for example, if the spleen is involved, there may be an increased risk of infections. If there's digestive organs involved, there may be problems with digestion. So depending on a lot of different factors, there will be a lot of different signs and symptoms, which may get hard to actually diagnose this condition. And this is going to be associated with mutations in genes that are associated with establishing the left-right axis. At least 20 different genes have been identified as to be a factor in this. Mutations in zinc finger transcription factor, Zinc3, especially have been noted, and this is involved in establishing the midline and preventing nodal expression. Other features of genetic syndromes, so it can be a part of a primary ciliary dyskinesia, which is characterized by chronic respiratory tract infections and infertility, and abnormal cilia appears to have a critical role in establishing the left-right asymmetry. So because of the fact that they have abnormal cilia, they don't have cilia to properly clear the respiratory tract, and infertility because the fimbriae are very important in moving the egg into the fallopian tubes. So this is associated with diabetes, smoking, exposure to hair dyes, cocaine, and it can also be idiopathic, meaning that there is no clear reason as to why this occurred. So pathogenesis, again, failure to establish the left-right asymmetry, and this can occur from a wide variety of different reasons. A correlation with the pathologist assistant profession. Insitus viridis can cause a wide variety of anatomical variations that may need to be accounted for in both the surgical and the forensic PA practice. And this could possibly come up with any specimen, really, but due to the association with heart defects, this condition can be seen in autopsies from heart failure. So it's always important to take this into consideration because different positioning of organs can completely change the anatomy and how these specimens will be grossed or how autopsies will be conducted. Here are some questions that you are able to go through on your own to reinforce your understanding of the content in this video. That is it. Thank you so much for joining me today.